Good evening, everyone. We welcome you all to OrthoTV online original webinar series. And today to introduce today's topic and speaker, I hand over to Dr. Salim Patel, who's a consultant orthopedic surgeon from Mumbai.
Yeah, thanks, Dr. Neeraj, and good evening to all our respected delegates. Today we are here to talk about our spine series where we continue the way forward. And for that, we have a very young, talented, and an eminent spine surgeon, Dr. Agnivesh Tikoo. He is a consultant spine surgeon at the Apollo Hospitals in Navi, Mumbai. He's done his AO Spine Fellowship from Park Clinic in Kolkata and his AO Spine International Fellowship from the Guy's Hospital in London. He's also done an IASA Spine Fellowship from the University Hospital of Wales, UK. And today, Dr. Agnivesh is with us to talk upon a very interesting topic, that is evolution of classification of thoracolumbar fractures and their management. With this, I hand over the session to Dr. Agnivesh. Over to you.
Thank you very much, Dr. Salim, and thank you, Dr. Neeraj, for giving me this opportunity. Thank you, OrthoTV, and thank you, Zydus. I will start sharing the screen and start without any delay. So yeah, is my screen visible?
Yeah, perfect.
All right. So I'll be speaking today about thoracolumbar fractures and the evolution of its classification, how it all began and where we are today, and a few key points about its management. It's an extensive topic, and you can not cover it in a single day as well, but I'll try to keep it short and to the point, relevant to the topic of this talk. So whenever we talk about the fractures involving the spine, the most devastating thing which comes to our mind is the spinal cord injuries. So we all, without any hesitancy, without any sort of confusion, should be very well versed in the initial management of a spinal cord injury, the timing, the blood pressures, the perfusion, the hemoglobin, everything we have to be aware about, and polytrauma care and steroids. Whether you prefer to give it, you do not prefer to give it, but you should be very thorough in all of this before you sort of deal with any spinal cord injury patients. I will not be touching these three topics, and I'll be straight away going to the classification so that we can understand how it all began. So question number one is that why do we need a classification? Why to classify it? Why not just call a spine fracture? The reason is that first is to name a fracture and give a hierarchy, because once you name a fracture, you can sort of categorize it in a way from where they are, how serious or how trivial they are. It also helps us to guide management. It helps us to predict outcomes, and it also helps us to compare results when you are seeing across the institute of different patients. You can sort of compare within those subgroups. So if we look at a classification, there's a huge list of classification which has been there in the spine fractures. But the one which we usually follow now is the TLIX or the AO classification. So it all started in 1930 when Boehler classified it into 5 groups: the compression fracture, flexion distraction, extension fractures, shear fractures, and rotational injuries. So these 5 fracture types are still the main fracture types which we still categorize them into. Then in 1938, Watson-Jones gave a concept about instability and its effect on the treatment of thoracolumbar injuries. And thereafter, the integrity of posterior ligament complex was considered to be essential for the spinal stability. There were 7 fracture types which were described, but the 3 major ones were the simple wedge fracture, the comminuted one, and the fracture dislocations. Now, it was also found out, and a very important point which is valid till today, is that stress to facet joints because of severe wedging anteriorly, if it is there, whenever there is a kyphosis which ends up more than 20-30 degrees, there's a severe stress to the facet joints, and this leads to chronic back pain in these patients. So 30 to 40% of these patients do develop severe back pain, which is disabling. Then there was a classification given in 1949 by Nicoll, wherein there were fractures based in coal miners and some types were described, and neural arch fractures, which are the posterior column injuries, were realized for the first time. And there were also structures were described which were contributing to the stability, and all of the spine was looked as a composite unit: the body, the disc, the intervertebral joint, and the interspinous ligaments. And it was also sort of postulated that interspinous ligament is the main stabilizing structure. Then in 1963 came the Holdsworth classification, which described the spine into two columns, the anterior and the posterior column. So it was based on the previous Nicoll system, and it was expanded, and burst fracture was described for the first time. And also a variant of burst fractures, whether they are stable or unstable, was also thought into. Otherwise, it was always considered that burst fractures are unstable, but stable burst fractures came into view, and they could be treated as compression fractures only. And in 1968, there was Kelly and Whitesides classification, where they sort of again considered burst fractures to be inherently unstable, but it formed the basis for the next classification, which was the Denis and McAfee classification. Now, all of these classifications, what we talked about, there was a problem in all of these. They were descriptive and anatomical, but they were not practical. They were not indicative of management options or outcome, and they were not validated. And there was a poor inter-observer reliability. What I may feel as a compression fracture, somebody may call burst, because at that time, the radiology was not so well developed also. Then in 1983, there came a classification by Denis, wherein a middle column was identified. Now, this middle column turned out to be a key player in the consideration for stability. So it was a CT-based classification, and there were three columns which were described: the anterior, the middle, and the posterior. And in general, if you have got injury to more than one column, it was considered to be unstable. So compression fractures were primarily a column injury, so stable. Burst fractures were A plus M column. Flexion distractions were middle plus posterior column. And a fracture dislocation by default would be all columns. But there was also a mention of this middle column in an earlier sort of description by Nicoll in 1958. So this was not a sort of de novo concept. Probably it was borrowed from previous sites. So, but one thing which was clear was even two column injuries, like a stable burst, still could be managed conservatively. So a distinction between stable and unstable burst fracture was still important. However, there still was inter-rater reliability issues were there, and there was no predictive outcome of this classification. Then again came the McAfee classification, which sort of stressed on the integrity of posterior ligament complex. It combined somehow the Denis and some concepts for instability, and differentiated between the bony chance fracture and the other flexion distraction injuries, which were purely ligament. We all know bony chance fractures have a very good union, whereas ligamentous injuries have a poor rate of union. Again, this was not validated and not tested for reliability. In 1984 came the Allen and Fergusson classification, and they sort of did not agree with the column concept, and they described this classification based on injury mechanism and the patterns of failure. It was a more mechanical classification because there was no sort of, it was not a clinical classification. It was not validated. It was too complex, and again, not predictive of outcome. One important management sort of tip or a management point came from McCormack and Gaines classification, which was the need for an anterior stabilization. What they observed is that in certain fractures, when you sort of just stabilize them short segment posteriorly, they were going into kyphosis, or they were sort of going, the implants were getting failed. So this was a time when pedicle screws had already come, and they were changing the sort of management of fractures. But again, the failure was a concern. So it was, this classification was given to describe whether you need an anterior surgery to provide anterior support and or not. So based on this classification, it was a CT based classification. Based on this classification, you gave three sort of points each to comminution, apposition, and kyphosis. And if your score was more than 7, then there was a high risk of short segment failure, and they recommended an anterior surgery. May I mention at this point of time that at that point of time, it was the posterior approach to the anterior column was not very well developed. So this still holds today to give an anterior column support. You may choose to give it posteriorly only by all posterior surgery, but the classification is still valid. It doesn't mean that you need to go anterior. It means that you need to go give an anterior column support. So again, this classification had some limitations, that there was not neurological status or ligamentous instability, which was taken into account, and it could not be used to sort of describe a surgical indication. And again, validation was an issue. And then came the AO classification, which was again based on 2 column theory of Holdsworth, and where 3 fracture types were described: A, B, and C. Now, in order of severity, A was the least severe and C was the most severe. And A1 would be the least severe and C3 would be the most severe, something like that. So A were primarily compression fractures and burst fractures. B were sort of chance fractures. It could be a ligamentous chance. It could be a bony chance. These two were B1 and B2 were inflection. And this was an extension chance or an extension destruction type of an injury. Whereas C were the rotation and translation injuries. Why they were important is that A had a 14% chance of neurological deficit, B had a 32%, and C had a 55% chance of a neurological injury associated. So they were predictive of severity of the fractures. Now, based on this, there's a very simple algorithm you can follow for this morphological classification, which is that if you see a X-ray, if there's a displacement of dislocation, it straight away goes into C, translation. If there is no dislocation, is it a tension band injury? And if it is yes, it goes into B. If it is no, is there a vertebral body fracture? If it's yes, then if there is a posterior wall involvement, it's a burst fracture. If it's no involvement, it's a compression fracture. And if it's just a simple fracture of say a spinous process or a transverse process without any other injury, it goes into an insignificant injury. And if all of these are negative, then there is no injury at all. The limitation is that the classification is very complex. There are even subtypes of A 1.1, 1.2, and B 1.1 and all of that, which sometimes becomes very complex to remember. It becomes confusing. And one of the major things which we did not realize is that none of these classifications took into account the neurology of the patient, which was a very, very important factor in determining the surgical as well as the patient outcome. And there was very little correlation between the MRI findings and the posterior ligamentous integrity in these ones. So then came the TLIX from the spine trauma study group. And this was based on the morphology of the fracture. They considered the neurological, which was there for the first time that this was taken into consideration, and ligament of the and posterior ligamentous complex was taken into account. Now, based on this classification, compression has been given 1 point, burst is +1, translational rotation is 3, and distraction is 4. So if you have a score of less than 3, it is non-operative. If it's a score of 4, it is operative or non-operative, you have to decide. And if it's more than 4, then it is a operative. But there were certain sort of situations where you would not be able to apply this. I'll come to that in a moment. But this one also gave some sort of directions how you should approach the surgery. So if the neurological status is intact, you approach it posteriorly. Even a minor root injury, you approach it posteriorly. But if it's a sort of a compression or a cauda equina, they recommended an anterior approach or a combined approach to decompress the cord. Now, whether the cord or the roots does decompression make a difference or not is another matter of debate, which I will also touch later half of in my later presentation. So there are exceptions to this TLIX classification. Please mind this error. This is TLIC, not TLIF. Is that if you have a kyphosis, you have open fractures, you have rheumatoid arthritis, ankylosing spondylitis, then this doesn't come into play. These are exceptional situations. You need to consider them separately as per merit of the patient. The limitations is that this classification requires an MRI to be done. all the centers may not have MRI, and you may want to, a patient with a neurological injury, you sort of want to wait and send for a MRI. If it's not available, crucial time may be wasted in that. And indeterminate PLC score of 2 can tell decisions. If it's 3, if it's sort of a fracture with a burst, with a sort of not burst will be 2, but if it's a slightly injury which is 3 and you have add an intermediate score of 2, it can tilt either way. It can go into surgical, which is 5, or you can add it 0 if you're not able to make out a ligamentous injury, which will still remain in the non-surgical way. So this has been a problem. And if there is a rotational injury and you sort of, the ligament is intact, there's no neurology, it's a very unstable injury, and you sort of will treat it non-operatively, no, that's not a chance, it will risk the neurology. So that again is a problem with this method. And validity about these validation studies are mostly done by the spine trauma study group only. Independent ones are still lacking. So to summarize, the strengths and limitations of each classification we need to understand. Always take into account AO classification plus TLIX plus Denis, and then choose your treatment according to that. And sort of do consider the adjacent injuries also involving the adjacent areas like discs and all into consideration while you are sort of doing the decision making for the fracture. And most important is that do not miss on the clinical examination, which is the most important thing. Now, neurological evaluation, whenever you have these fractures, we used to follow the Frankel scale, which was a very simple scale from A to E, which sort of was from the bad to the recovery sort of a thing. But nowadays, the one which is most usually is the ASIA scoring, or the American Spinal Injury Association. It's a 2-page chart which can be printed one on back of other, and it has got all the details about what muscles to be tested, what sensory areas to be tested, and then you give a score on the sort of the light touch and pinprick representing the appropriate columns of the cord, as well as the motor, which would represent the pyramidal tract. And you combine these scores, and this gives you a sort of score to compare with. And based on this, you have a ASIA impairment scale, which describes the injury as complete A when there is no sensory or motor function preserved in the sacral segments, and E is normal. Now, let me make it very clear that if you have a patient whose neurology is normal, the ASIA score does not apply, because it's E is only for a patient who has recovered from C to E or D to E. Somebody who has presented with a neurology and who has recovered, you use ASIA E. But somebody who presents to the casualty with a fracture and does not have a neurological deficit does not qualify for ASIA scoring. So you don't mention an ASIA score for a patient who is neurologically intact. So, and this ASIA score also helps us to predict the prognosis of the patient. So this is if the ASIA score, what was the ASIA score at 72 hours of examination of presentation of injury, and this is the 1 year follow-up grade of the same patient. So we see that A is the complete injury and they do not recover. So if you have 100% patients who presented at A, only 84% of these just stay like that. They do not improve, and very few persons will get meaningful recovery, which is 3%. Whereas it's reverse with respect to D. If you have somebody who presents with motor deficit, which is at least grade 3, and they do recover, 85% of these patients, they stay there or they improve, and they have a higher chance for recovery. Another interesting article which was there, which was sort of addressing the question, who is going to walk? So again, this shows the severity. If you have a ASIA A, sort of a cervical lesion, which means complete injury, none of them recover. This is a real devastating situation. And even in thoracic or lumbar lesions, they do not recover. Less than 5%, less than 10%. That is how they recover. And sort of, if you have only light touch preservation, still it does not give a meaningful recovery. But if you have a light touch plus pinprick preservation, sort of you get many patients who would walk and have meaningful recoveries. And again, people who have ASIA C and are young, better prognosis. ASIA D anyways has got good prognosis. Most of them do recover over a period of time. Now, let me show you a few case examples. This is a 23-year-old male, had a fall, Asia D. You can see this fracture over here, a L3 wedge fracture. You may consider it as a compression fracture. But when you see very clearly, you can see the opening up of this spinous process. So this is actually a chance type of a fracture. So this is not a simple compression fracture. And this qualifies for a surgery. And there's a neurological deficit also. So this does qualify for a surgery. So it's a type B injury and you need to sort of fix it and stabilize it. Now, another case, road traffic accident, Asia C, and this is again a fracture. You can see a line running through and through from here to here. So this is again a 3-column injury, a CT scan, you can see a sagittal cut, you can see slight retropulsion. But when you see the sagittal cut clearly, you can see this bony fragment, which is a part of this chance fracture, which has lipped off completely. Again, a type B injury, and you need to fix it, and you can't treat it conservatively. Another case, a 50-year-old female, fall from height, neuro intact. There's a unstable injury. There's a ligament. You can see the hyperintensity over here. There's a ligamentous injury. It's an unstable injury because it's involving there was a posterior column crack also, not very well seen here, but on the CT it was there. So it is a type A injury, and these you can treat by percutaneous fixations. You don't need to sort of open up for them. You just can percutaneously fix these fractures and mobilize them early. Now, one question which I had left was that in thoracolumbar fractures, decompression, is it necessary? Because it's a very big decision. Your reason for going anterior is decompression of the cord. Your sort of prognosis is dependent on this decompression of the neural structure. So it's a big debate, and there are few points about it. One is that we believe that you should always and always decompress, and the other says that it does not change the sequence. Now let's try to have a look. Whatever you see on the MRI or an X-ray at the time when the patient comes to you, it's not a true picture of the actual impact. These two cars collided here and then they separated away from each other, and they will be seen in a much better position than this one moment when it actually happened. So the final position of the fragments on an MRI or an X-ray does not represent the true sort of compression which caused the injury. Now, there was a sort of a very beautiful article which was there in which an experiment was done, and sort of they tried to do a correlation between the bony canal disruption and the degree of neurological compromise. But the thing is that they sort of, it could be caused by the injury severity score, but still it is again the trauma, the injury which has happened at that point. You could sort of correlate it with the injury severity score. If the injury is very severe, you could sort of have a higher neurological deficit. Low energy trauma would definitely would result in less neurological deficit. So this was that experiment, a very beautiful experiment which was done, wherein sort of gelatinous cord was used and with pressure transducers, and then impact was given to study the sort of effect of neurological compromise, what happens. Now this is the sort of view of that gelatinous tube. See how the injury happens, and this is at the peak of the injury. You cannot see anything in that canal. You cannot see anything in that gelatinous cord. It's all compressed, and this is what it comes to resting position. So this is what you see on an MRI, and this is what actually happened. So if this is what is seen, it's already better. The thing is, the cord is already decompressed. Do you really want to decompress it? The dura may be torn, and there may be other sort of injuries and CSF leaks also present. So you need to have a very strong reason to go into the cord. So this was a very beautiful experiment which was done. And the second is that the canal can remodel. So this is a CT scan of a 52-year-old man with a burst fracture taken from one of the studies, which showed that there is a fracture at L1, and it does sort of recover and remodel over a 1-year follow-up. You can see the fragment over here and see it's all completely gone. Another case where it shows that there's a compression or a fragment which significantly resolves at 1-year follow-up. So one very important article which came from our very own respected person, Dr. S. Rajashekharam, whom we all respect and look at us as a role model, which sort of had a look at these thoracolumbar burst fractures without neurological deficit, and sort of impressed that a lot of these fractures can be treated conservatively, and sort of that you should be uh, the geometry of the canal, the fracture what you see is not a good guide to the extent of neurological dysfunction, and the surgical decompression of the spinal canal will not alter the prognosis in these cases. So a lot of these can be sort of treated conservatively, and this is a very important study which comes because we tend to see the fragments on an MRI and think that surgery is needed, but this study showed us that a lot of these could be managed conservatively also. Another study which showed that mostly 50% of the retropulse fragments, they get resolved in 1 year, and this is the beauty of the human body, that they sort of remodel. Again, another study which sort of did impress that the recovery rate was significantly related to the stenotic ratio at the first examination. So this was one study which impressed that the neurological recovery is sort of dependent on the stenotic, the ratio, the compression of the cord or the spinal canal at that time. So this would mean that probably decompression does help. So another study which was presented in European Spine Journal, which showed that canal encroachment was further reduced, and it's only 2% of the encroachment which remains at the end of 12 to 15 months. So the canals can remodel, but yes, impending compression in event of incomplete neurology is something which we should not miss. And these are the cases which should be decompressed. If no neurology, there is no need for decompression. If there is an incomplete neurology, it should be decompressed. The complete neurology, it's a surgeon's decision whether he wants to decompress. If there is compression on the cord, then definitely the patient should get a chance for decompression. And in certain cases where there is not much of neurology, we can easily aim for indirect decompression. This is again a study which was published in 2011, which showed that with indirect decompression, which is ligamentotaxis, which you can easily do using a monopolar screw system, or even now mono screw system, and even now with the poly screw system by attaching certain attachments, you can just pull up these fragments, and with the fragment which is in the canal will automatically get reduced because the ligaments up and down tend to pull it. So this indirect decompression should always, it's very helpful, and it can be attempted in certain cases. Again, another case which shows that this fragment can get sort of pulled back, and canal can get decompressed. Now, the question is, in case of a complete injury, how does it sort of matter? Does it really matter? So does the surgical decompression result in neurological injury? I would point towards one of this paper, which said that these were 12 patients who were operated. And though the delay in surgery was quite significant, it was 11 days, they were not operated early. And only one patient of these recovered from Frankel A to C. This is a group of complete sort of thoracic spinal cord injuries. So I would leave it to the surgeon to decide that if the situation allows and the surgeon is comfortable, definitely a decompression should be done. The patient should be given the best chance for recovery. But the fact is that you need to keep under consideration the dural lacerations, and whenever you go in for a surgery, you need to have all of that repair things in your mind. That if there is a dural laceration and if there is a shredded dura which I cannot repair, then we should have backup available like artificial dural patches and sealants and all that, which we should be well versed with to repair or sort of control that CSF leak over there. To summarize, I would like to mention that initial management is the key. We should identify and classify a fracture. It has an effect on the outcome. and appropriate treatment is the key. We should not end up operating a patient who does not need a fracture, or sort of operating a patient who actually is unstable and does not fit into our criteria. So clinical judgment is very important, and neurology needs to be given the prime importance. Any patient who has a neurology, by default, his injury is unstable. If the injury has been, if the injury has been so severe that it has called as neurology in thoracolumbar spine, the injury is unstable. And social and rehabilitation part after the surgery should not be missed. That is the most important part. Thank you very much.
Thank you, Agnivesh. It was indeed a very nice presentation. I learned a lot of new things about the classification and about the different types of surgery that you do. So I would like to start with asking you a few questions. There were two cases which you showed, in which you had put screws in the fracture vertebrae as well. So how
Yes,
do you decide whether this requires a fractured vertebrae screw or it doesn't require? Does the classification help in that?
No, the classification actually does not help in that. But why do we put a vertebral fracture screw? Is because we want to shorten the lever arm. Once we fix the upper and the lower vertebra, there is a sort of a lever arm which happens between the two vertebrae. And we also want to give some rotational stability to it. A single level fracture fixation above and below is rotationally unstable. So in those cases, if the pedicle is not burst, or you are not going to displace the vertebral fracture, we tend to put a short pedicle screw. It's usually a screw which is just crossing the pedicle and which will not sort of go into the fracture area or be in the comminuted area. So it helps us to get a rotational stability, and it also reduces the working length of the construct. So it adds to the stability of the construct.
Okay. And about this classifications which you described in detail, now there is this thing that basically what is the timing of the surgery when these type of things happen. Like they say that what I had heard during my postgraduate days and even now, that if it is an incomplete neurology, you should be operating the patient as soon as possible and not wait for the next day. But if it is a complete neurology, then maybe you can wait it out and then maybe operate. Is that still holds true, or basically it does not make any difference?
No, the first aim is to let the patient stabilize. Sort of, if you have a patient who has got concomitant other injuries like a chest trauma, blunt trauma, his blood pressure is not stable, you can't take such a patient to OT. His priority is the life-saving surgery first, or the life-saving measure first. Now, if it depends upon the center, if you are comfortable, the patient is absolutely stable, patient has an incomplete neurology, I don't mind taking the patient in even in the night also. But if the patient is sort of otherwise unstable, or you are not comfortable with the sort of situation, you can always post the patient the next day morning. I'm talking about a patient who comes late in the evening. I'm not talking about the patient who's coming in the morning. Whoever comes in the morning and is stable to be taken up for surgery, preferably should be a patient with neurology should be operated as early as possible. I mean to say that patient should be well prepared. You should work up the patient well and keep him appropriately, NBM and all. So you can target for that area, right? But if the patient is unstable, or you are not comfortable operating in the night and the patient has presented like in the evening, you can always post as the first thing next morning. I think there's more harm can be done if you try to rush the patient in the night when you are ill prepared, your staff is not trained, and you don't have the complete equipment at hand. It is always wise to have everything at hand before you take such a patient in operation theater.
And you have told about the sensation and everything. I don't remember you talking about the bulbocavernous reflex. Is that still important doing a PR, or when your patient is catheterized, just tugging on the catheter? Is that still important in today's day and age?
Yes, it is. It is very important. I did not mention about that because, as I said, I am not going to discuss the spinal cord injury part. So whenever you sort of label a patient Asia A, you have to sort of check all of these things. You have to check the anal wink, you have to check deep anal pressure, you have to check all of these reflexes and all, and then only you can sort of make the patient label as Asia A. Even if you're labeling somebody as Asia A, you recheck them after 24 to 48 hours, because many of them are in spinal shock. And one of the ways to understand the spinal shock is what you exactly said, is the bulbocavernous reflex. Now, if there is a cord injury and the patient's bulbocavernous reflex is positive and he does not have any other sensation, no sensation in the legs, perianal sensation absent, anal wink absent, deep anal pressure absent, he does not have any voluntary anal contraction, you have to label him as a complete spinal cord injury. So it definitely, bulbocavernous is a very, very important sort of reflex which you have to keep in consideration.
And I've also heard from my spine surgeon friends when we operated such a case together that if the bulbocavernous reflex is present or the anal wink is present, he has a better prognosis compared to when it is absent.
I would say that with anal wink, but not with bulbocavernous is classically reflex, which if you have a upper motor neuron injury and
Okay.
you have something, you have a bulbocavernous reflex which has come and there is no other recovery, it is most likely a sort of a complete cord injury. And complete cord injuries, they rarely recover, as we discussed in the talk as well. They are more than 85-90% of them stay like that only. They do not recover. The chances are very, very less. But yes, it can happen. Now, anal wink or anal sensation is different. If patient does not have any sensation, any motor part in the legs, but he has a anal sensation present, like a deep sensation, S3, S4 sensation is present, you label the patient as incomplete cord injury. You label them Asia B. You do not label them Asia A. So bulbocavernous for determining the complete cord injury and anal wink or anal sensation for describing the sort of incomplete cord injury. These are two things which we have to keep in mind and have a look at them separately.
And about this Asia paper which you showed, is it available online and it is free to use?
It is free to use. Yes, yes. It is available online and you can use it with your patients and you can sort of compare them. You get a score with that and say the patient comes for follow-up after surgery, 3 months, 6 months. You can use that score to sort of compare the increasing output, because the patients may not change the scales, impairment scale so soon. Like somebody may not get translated from C to D in a week or in 2 months or 3 months, but their scores will start improving. So you know that the patient is recovering. And it also helps you to measure the zone of partial preservation, which is there in complete cord injuries. And if there's a complete injury, you know the zone of partial preservation, you can expect some recovery in those zones. So it helps you to sort of prognosticate and sort of manage the patient and rehabilitate the patient easily.
Okay. So I think that's all from my side. Over to you, Dr. Salim Patel.
Excellent talk, Agnivesh. My
Thank you.
question to you is about a paper which you had shown about retropulse fragment. You're saying
Yeah.
more than 50% of these do recover. So
Yeah.
So my question is, whenever you get a case like this in which there is a retropulse fragment, how do you evaluate when to take up and when not to take up for surgery?
So see, a retropulse fragment without a neurology is, you do not aim for decompressing that, you aim for fixing it. If it's an unstable situation, you fix it and just leave it and let it heal, it will remodel itself. The question comes when the retropulse fragment is associated with a neurology. You are going to operate because it's a neurological deficit, it's an unstable situation. The question is whether you are decompressing the cord or decompressing the neural structures or not. If you are able to achieve it by sort of indirect decompression and ligamento-taxis, and it's not a sort of a major bony fragment which is impending compression on the cord, you can sort of do an indirect decompression and call it a day also. But if there is sort of pressure on the cord and it's a major bony fragment which has retropulsed and it's pressing on the cord still, you know it's not going to absorb soon. So then in that case, it is better to decompress, especially in a case of an incomplete injury, because you want to give them the best chance for recovery. So whether you go anterior, you do it from all posterior is a surgical choice, but a decompression in incomplete cord injury is probably a right thing to do.
Right. Excellent. Another question related to spinal cord injuries now. The famous, you get a patient of spinal cord injury, we always think about methylprednisolone. So what are your views on that? How much would you like to give and how early you like to give?
So if the patient is presenting to the casualty, what I usually do is I give the bolus dose and if they present in time, and by that time I'm already engaging the relatives into the discussion. I tell them all the pros and cons about giving the steroids and sort of not giving it, the side effects of giving them, chest infections and other problems which can happen, versus sort of a, scenario where the recovery may be a bit less. But again, it's a huge matter of debate. How did the steroids come into the picture and how the dose was calculated? So if you go through all of this, it's, to me, it's not very convincing. But what I usually do is that I discuss this with patients, tell them all the pros and cons, and I take a shared decision with the patient whether we are going ahead with the steroids, giving them steroids or not. Obviously, if it's a severely diabetic patient with uncontrolled sugars, or there are multiple open injuries and all, you have to sort of take all of these points into consideration before you think about giving the steroids.
Right. Excellent. Excellent. Yeah, Neeraj, over to you.
Thank you, Agnivesh. We thank Dr. Agnivesh Tikoo for sparing his precious time and sharing his great knowledge on classification and opening up our eyes. This will not only help the people who want to become spine surgeons, but it will also help general orthopedic surgeons classify the spinal fractures which they will see in their practice. And I thank Dr. Salim Patel to be on the panel with us. And I thank all the audience to be with us every weekend on Saturday night. So bye-bye, everyone, and good night.
Thank you. Thank you, Dr. Agnivesh. Thanks a lot.